Thank you very much, Dr. Ruchiman. So we're going to start the opening ceremony now. Good morning, honorable speaker, distinguished delegates, ladies and gentlemen. First of all, I would like to introduce myself. My name is Dr. Kitisak Unsisong. I'm from Chiang Mai University, and I will be the MC for this opening ceremony. It gives me great pleasure to extend to you all a very warm welcome on behalf of the Association of Thai Interventional Neuroradiology, or we call it shortly ATIN, and to say how grateful we are to see a lot of participants attending our third annual meeting this year. Today we have nearly 120 participants joining our conference. This is the first time that the conference has been moved from Bangkok to outer regions of Thailand. So to make a thing short, next I would like to invite Associate Professor Anchali Churojana, our President of the ATIN, to deliver her welcome speech. Dr. Anchali, please.
Thank you very much. So, dear colleagues, friends, ladies and gentlemen. So, on behalf of the Association of Thai Interventional Neuroradiology, I would like to welcome you all for our third annual meeting with the theme of Strengthen ATIN003 Future with Anatomical and Technical Integration. Our society, although it has been officially established for only 3 years, but actually our work and our responsibility for ATIN003 field had been started long time ago in Thailand, I think for more than 20 years. In that time, with the respect to Professor Suthisak Suthiphongchai, who is our teacher, my teacher in Thailand, I would say that he was the first ATIN003 in Thailand. And fortunately, that time, there is a friendship or relationship MOU between Thailand and France. And he has a chance to introduce Thailand to Professor Pierre Lajeunesse. I hope everybody knows Pierre Lajeunesse. We don't have to talk much about him, although he passed away. But everybody in this world recognizes Professor Pierre Lajeunesse as the first and the teacher of the ATIN003 in the world. And this is lucky of Thailand. After that, Pierre Lajeunesse, the first time, if I remember well, he visited Bangkok, Thailand, and start the first embolization in Sirat Hospital. I think, if I remember well, it may be in 1990. And since then, I will also say that is lucky of Thailand. Pierre Lajeunesse loved Thailand very much, and particularly here in Chiang Mai. Not only keep on since 1990, he keep on coming to Thailand every year, every 6 months. And not only that, he organized the first planet course since, I think it's in the year 2000. I think this is the first course in the world that he tried to teach the ones who are going to be in this field to know about, relate about the knowledge of the functional anatomy and correlate with how to can be about the disease and how to do the embolization. And at that time, it is a 2-year course, and we call that a Chiang Mai course, and that's the reason why, how come that we choose Chiang Mai for the place of this meeting with all good memorable with him, and also with Professor Insub Choi, that are the first join us for the first planet course also. And for this meeting, it is my honor to have very world famous intervention neuro interventionists that include Professor Insub Choi and Professor Jack Molay and Professor Christophe Coquillard, Professor Baxter with Lucy Tribu, and including all Thai speakers. and particularly with all the support from the oil companies right there, and also outside, and particularly for all participants who come here and make this meeting very successful. So finally, I hope that everybody will enjoy the fruitful of our scientific meeting with that kind of case discussion and sharing experience, and hopefully, particularly you who come from abroad, that can have the chance to appreciate the unique charm of Chiang Mai, which is one of the top cultural destinations in the world. So I think it's a proper time to get started. Please, thank you.
It is a pleasure to be here in Chiang Mai again. I think that this is my close to 30th visit in Chiang Mai, and it is like my third hometown. And we had great memories together with Pierre and spending times. And I think more than half of the attendees seems like went through all this Chiang Mai course as well as Planet course. I appreciate Anjali for your kind invitation, and it's great to be here and see old friends again. As usual, she gave me some tough topic to talk about it. Okay? And I spent a lot of time to think about what should I talk about this arterial variation and aneurysms. Okay? And so this is the way I prepared. And we have to understand what arterial variations, what we see in our practice. On the basis of the embryology, we can divide into different arterial variations in the neurovascular system. We certainly see agenesis, hypoplasia, persistent embryonic vessels, and duplications and fenestrations. The ones which often we see associated with aneurysms are mostly duplication and fenestrations, but occasionally we may see some aneurysm associated with the persistent embryonic vessels. These are some of the persistent embryonic vessels in the humans. Okay? Most commonly we see the trigeminal arteries, and less commonly primitive maxillary arteries, or these arteries, the the physicians who went through the Planet course or Chiang Mai course, you will remember what all these vessels are located. Certainly, it's not common to see the association with these embryonic vessels except the trigeminal artery. However, I'm going to show you a couple of cases of the examples. This is one of the persistent hypoglossal artery. It's not directly related with the embryonic vessels, but one of this patient had this multiple aneurysms, as you can see, and the large posterior communicating artery aneurysm, as well as a left internal carotid artery aneurysm. You remember we talked about this persistent hypoglossal arteries and many times before. Another example I'd like to show you, this is not directly related with persistent embryonic vessels. However, this is one of this rare example. Patients do have aneurysm and persistent hyostapidial artery system. As you remember, some of you, and hyostapidial artery is a failure of the connection between this growing ventral, aortic system did not hooking up with the hyostapidial system, and that's why you have this persistent arteries, as you can see, and you can see these arteries, the internal maxillary arteries coming from that internal carotid artery itself. More often we see the trigeminal arteries, but we often see aneurysm associated trigeminal artery directly too. This is one example. You can see the aneurysm originating right at the origin of the trigeminal artery. You can see the retrograde flow to this trigeminal artery as well, and vertebral artery injection. Why this happens? Pierre told us this is most likely because of the premature or immature vascular system network, the whole vessel wall. That's why we may see more often in association with embryonic vessels. It may occur in the middle of the vessels itself. This is one example. You can see the trigeminal artery, and 3D image certainly shows there is an aneurysm in the middle of this trigeminal artery. And sometimes you see an spontaneous carotid cavernous fistula associated with the trigeminal artery. You can see injection of the internal carotid artery certainly shows evidence of a fistula and carotid cavernous fistula draining into the ophthalmic as well as inferior petrosal. And it is also opacified from the injection of the vertebral artery, which indicates there is embryonic connection existing. And following the coiling of this aneurysm itself, you can see the persistent filling of the trigeminal artery and vertebral artery itself. Actually, more often we see association with embryonic or variation of the arterial system is duplication or fenestration. Okay? What is duplication? What is fenestration? Okay? We certainly have to separate what duplication and fenestration is. We used to combine or mixed up with the fenestration duplication, but the definition-wise, duplication indicates there's two different channels. Okay? Embryonic vessels fail to regress. Okay? Some of the embryonic connections supposed to regress but persisted. Fenestration is, by definition, two lumens correspond to the single path, failure of the fusion. And supposed to have some embryonic systems when you have a loose network of the vessels, which is supposed to make a one channel, but fail to completely fuse and make one channel. So you may see the two separate channels. Pierre separated non-union or vertebro-basilar system from this fenestration, but by definition, it's more of a failure of the fusion as well. Non-union you see in the basilar artery or spinal artery, anterior spinal artery. It is due to the incomplete fusion of the ventral longitudinal arterial axis. Duplications, let me show you some examples. Duplications, this is a rare, I think it's a very rare case of duplication of the carotid arteries. And cervical portion, this is failure of this second aortic arch regression. And second arch supposed to regress, but it persisted, so making this duplication of the internal carotid artery at the cervical portions. More duplications or fenestration we see in vertebro-basilar system. This is Paget's drawing of this, the development of the vertebral artery. Vertebral artery development is connection between the segmental arteries in cervical portion, which eventually make it channels and make it this vertebral artery system, as we all know. Therefore, in the process of this connections, it may make it one channel rather than make it two channels. This is one example. You can see two separate vertebral arteries. This is certainly duplication, not fenestration. You can see the two separate origins of the vertebral artery because of the failure of the connection of the one of the intersegmental arterial system. This is one example of the duplication of the higher cervical vertebral artery system. You can see duplication of the C3-4 level as well as a C1-2 level. This is the diagram. Most of people who went through the planet course remember these diagrams, what the Sirintara often suggests to see you. In addition, we do have occasionally see the fenestration of the cervical portions. And as you can see, there is a separated two channels of the cervical portion of the vertebral artery itself. Fenestrations are more often we see in the higher level, C1 level, and this is one example of the fenestration of the C1 vertebral artery. You can see there's two separate channels, and another example of the fenestration, and actually fenestration showing you the pica is originating one of the channel of the fenestration at the C1 level. Not only in the vertebral artery system, we also see the carotid artery system as well. Unlike the duplication I showed you previously, this is a fenestration of the internal carotid artery. Professor Pongpech gave me this case to me, and this is actually, I do believe this is fenestration rather than true duplication. It's a little different from the one I showed you before. Because of the fusion process of all systems along the midline, we see often fenestration or the double channels of the anterior communicating artery system. This is example. You can see a hole in the anterior communicating artery, and this is another example of the hole in the anterior communicating artery. Not only at the anterior communicating artery, you can see at the A1 segment as well. You can see the fenestrated segment of the A1, or right at the bifurcation or the origin of the middle cerebral artery. And this is one specimen, Philippe Massier gave it to me. This is, you can see the separated M1 segment, two separate locations of the M1 segment. Also, we often see in P1 segment, you can see a fenestrated segment of the P1 segment. And this often, you see the third nerve going through this fenestrated segment and documented in dissected specimens as well. Some of times it's difficult to separate whether this is fenestration or duplication. It is too much of separations. And this is another example, maybe two channels developed or separately from that original pro-atlantal systems. And also, there are examples of the double origin of the picas, and pica, this is two separate origins of the picas you can see, and there's many examples you probably experienced as well. And also, you'll have associated aneurysms of the pica origin as well. In this case, specific case, patient presented with the subarachnoid hemorrhage, and fortunately he had this two picas, and in spite of the occlusion of the one pica origin, and distal territories are filled from the second channel, you can see coil. During the process of the coiling, this was occluded from that coiling process because of the wide neck. Non-unions are, we see the vertebrobasilar system is due to the incomplete diffusion of ventral longitudinal arterial axis, and this is one example of fusions. And let me show you some of the basilar artery. It can be from the vertebrobasilar junction, or it can be a distal segment and distal areas of the fenestrated segment of the basilar artery, because of two longitudinal arterial axes supposed to fuse completely, but incompletely fused. This is because of that embryonic process it persists. And this is Jacques Dion's case, which presented, published many years ago, is completely separated vertebral artery, two separate channels of the vertebral artery system. Remember, there's a permanent non-union and fenestration, and that's at the segment of the vertebrobasilar junction. The anterior spinal artery, we often see the two separate origins. This segment is permanent non-union, embryonic non-union of that longitudinal vertebral artery system. Let's look at the topic of fenestration and aneurysms. Incidence, okay, how often we see the fenestration? Fenestration of incidence was about 10%. This was published in a long time ago, 1967. This was more of the cadaver injected specimens they documented in the cases of the cadaver. 291 cases were injected and studied, and they found 28 fenestrations. And there is also another report from San Francisco. They look at it, all the cases of angiograms, and they found 2.1%. So it is by report to by report that the presence, incidence of the fenestration is a very variable. Okay? And why we see the fenestration and aneurysms, okay? It is because of the incomplete media. There is a lack of a media at the fenestrated segment. This is a documentation published a few years ago. They found this media is incomplete as the inflow as well as outflow zone of the fenestration itself. That's why we do have more of aneurysms at inflow because of the hemodynamic balance, as well as this lack of the fully developed media itself. You can see the aneurysms in this internal carotid artery. This is a rare example of the fenestration associated with aneurysms in the internal carotid artery. This is another example of the large aneurysm developed from the fenestrated segment of the internal carotid artery. You can see large aneurysm coming from the inflow zone of the fenestrated segment as well. This is one of these good examples of the aneurysm developed right at the inflow zone of that fenestrated segment. You can see the hole in the M1 segment that this aneurysm developed in inflow zone. So remember, we often see the more inflow zones and this complex, incomplete, immature blood vessel walls. That's the triggering factor of development of the aneurysm itself. This is more complex A1 segment aneurysm. There's a multiple lobe aneurysm, as well as small separate aneurysm from the complex two separate fenestrated segment of the anterior communicating artery itself. This is an unusual, rare example of this aneurysm developed in outflow zone of the fenestrated. You can see the fenestrated segment of the aneurysm was developed at this distal segment of the fenestration of that M1 segment. Not only you can see rarely, but you often see a vessel itself has some development of the aneurysm as well. If you look at it, okay, it's not common to see these aneurysms, and as you know, so as the fenestrated segment as well. And there was a publication many years ago, 1987, and Campos is a Portuguese interventional neuroradiologist. When he was working in London, Ontario, during 1987, he reviewed all the cases of Charlie Drake's vertebral-basilar artery system. He found 59 cases treated by Charlie Drake and his group, and they found 21 cases was originating from the fenestration. This is relatively high incidence of the aneurysm, considering the rare location for this clipping. And this was all total 35.6 cases. We also had some of the vertebral-basilar junction aneurysms. Total number of cases in my personal cases were 22 cases. To prepare this talk, I look at it, what the features are, and we had 73 percentage of those cases were from fenestration itself. And subarachnoid hemorrhages were 6 out of the 16 of fenestrated segment, 2 out of 6 of the without fenestrations. So the cases I treated has a very high incidence of association with the fenestrations. These are type of the aneurysms we see. There's a small aneurysms, you can have a large aneurysms, or you can double dome aneurysms. Okay? And there is also large posterior projecting aneurysms, and this is multi-lobe aneurysms as complex shaped as you can see. So I don't know because of the the referral patterns, but I did have a high incidence of the vertebral-basilar junction aneurysm with the fenestrations. One other thing we reported many years ago, this when aneurysm right at the vertebral-basilar junction, if aneurysm is projecting inferiorly, that's without fenestration. But if aneurysm is projecting superiorly, any direction anterior or posteriorly, that's with the fenestration. Okay? And this is one example. You can see this is aneurysm coming from the fenestration, projecting superiorly, and this is projecting inferiorly. This was without the fenestration. And this is one example. You can see the vertebral-basilar junction aneurysm. This is pointing. superiorly, even though anteriorly. Okay? And in ordinary angiogram, regular angiogram, we cannot really see there is a fenestration or not. But if you look at it, 3D angiogram, there is certainly evidence of the fenestration and with a large aneurysm with a daughter sac. Let's look at it again. This is one example. Aneurysm is pointing superiorly. Okay? But regular angiogram does not show fenestration, but you can look at it. This is fenestration, and aneurysm is pointing superiorly. Okay? How we manage these aneurysms? This is even the old case before era of the stent or flow diverters. This was a double dome aneurysm, one projecting anteriorly and one projecting posteriorly. What I did was we closed the posterior dome first. Then we changed to go to the right ventricularity and close the left side dome, the anterior projecting dome, and then we went back to the left ventricularity and then closed the rest of it. You can see the heart-shaped cold mesh itself. This is one example we treated without stent. I tried to go into the stent, but the catheter did not follow the guide wires. This is so difficult to navigate, even though we even put the guide wire in this internal carotid artery through the posterior communicating artery. I could not really pass the catheter itself. So what we did with a coil alone, you can see gradually filling up this, forming the basket, and this is final result. And after, I think, 39 coils, you can see the complete occlusion of this aneurysm. Even though it was a very wide neck, you can make it this way. This is follow-up studies. Some of the aneurysms, and this is initially treated with a balloon-assisted coiling, but there was a follow-up recanalization of the aneurysm itself, and this time we did have already stents, so this was treated by stent-assisted coiling as well. This is another complex aneurysm. You can see at the vertebral-basilar junction. I initially treated in 1997 the inferior, the projecting aneurysm itself. Superior projecting aneurysm, I couldn't treat it, so we left it alone. On follow-up, she did have a separate aneurysm developed from the fenestrated segment itself. So I had to treat this one first, and then rest of it treated with the stent-assisted coiling. And you can see the stent was placed and aneurysm was completely closed with this way. And follow-up study shows persistent closure. So in conclusion, I don't have definite numbers to show you, but there seems to be higher incidence of aneurysms at the site of the arterial variations, especially fenestrated segment. Okay? Recognizing presence of the fenestration for the vertebral-basilar junction aneurysm is helpful in planning how to treat such complex aneurysms. Thank you very much.